I'm Dr. Debbie Tomek. I'm the Associate Medical Director for the Center for Child and Community, and I'm really honored to be able to talk to you about what we're doing at Children's, and really have appreciated our partnership with the Douglas County Health Department. I feel like we are now truly partners in the field, and I haven't always said that, as you know. So real thankful that you exist and that you push us to do what is the right thing in our community. So thanks for this opportunity. All right, let me see if I can run this. Children's has a strategic plan just like all other hospitals, and we are on it. And that's a big step in the forward movement because we haven't always been there. That community now is a part of health, and our strategic plan is showing that. So right now it says engage the community. The next time in 2020 it's going to say partner with the community. Okay, so we're moving down that continuum of care of meeting and greeting, and now trying to actually do the work together. Putting children's in the community health part. This has not been, as we've said before, a high priority in our organization, but now has becoming, with the creation of our center, this Center for Child and Community, and this is actually our mission and goal for the center, not the Children's Hospital goal, but it's really to empower communities, and I know empower is not that word we should be using, so we may have to wordsmith a little bit to really communicate well, but to really value the support of health and safety and well-being of every child, okay, not just the children that come to our place. And then really to coordinate and build a community platform that addresses the whole child, not just perhaps the acute reason why they have come to see us. Collaborative partnerships. This is where our work is really getting traction within the children's community. We sometimes in health look at each other as competitors, and so we have to stop doing that, all right? Because we are not going to be able to solve hunger, transportation issues, housing issues, the things that really help determine people's health without having a partnership with those who are reaching the folks in need. And so that means that we have to put aside our perhaps competitive natures in some ways, and to really use that to work together. And so I do not have that impressive a list of partnerships. Okay, so I have a goal. Okay, I am going to get a bigger list of those partners, mostly because we don't. So far, we've been so busy doing the work that we haven't done a very good job documenting our work and collecting that kind of data points, because first of all, we're a lean and mean group. Okay, you're seeing the Omaha component of this, but we recognize that in order to show the difference, just like what you've seen in your presentation from Methodist, that we need to do a better job of showing what we're doing, so that way we can be held accountable for doing more. So we're really working on these non-traditional partners, trying to build some momentum and traction. This is our logo list of partners. There are many that stand behind, but these are the ones that are really the rich ones. And we're, like I said, Douglas County Health Department right over there in that corner, as well as Lincoln Lancaster Health Department. Because our center is focused and housed in Lincoln, we have really a rich relationship with that community, and are building really adding that child health component to most of what happens in the Lincoln community. I'm not here to talk about that, but you need to know that that's happening as well. Okay, we're raising the bar in community health. Last time I looked at what I told you, so I'm going to pick up the ball from there. We promised that we would go to the community to talk about our priorities, and so we did. We went and partnered with Live Well. We went to and participated in that Changemaker Summit. We listened to the community and heard from them their highest 4 priorities. And so we thought, okay, that's very good and interesting. How can we really narrow our focus instead of this very broad 11-topic priority list, which is what we got back from our PRC Child Health Needs Assessment? How can we really focus that into things that categories that we can go deeper in rather than just trying to buckshot across all those priorities. So we took this back to our internal group. We have now an advocacy group we've created since we last met of internal folks, again, passionate about community health, already doing advocacy in the community. And we asked them, where do you think we should be? And they were not at the summit. They did not know what the community said. And we presented all the material to them. And they also picked those top 4. So we know we're in the right zone. The access to care, mental behavioral health, nutrition, physical activity, and obesity treatment and prevention, and sexual health. So the impact areas that we have at this point are working it within the early childhood systems. We're just beginning to tap some of that potential in Omaha, but within the Lincoln community, we are the health component there. In Omaha, I think we have some more work to do because there's lots of people doing lots of things. We've started partnering with MOAC and looking at their Raise Me to Read program, and so we have some work there that we're beginning to do outside of just the traditional boundaries of health. Clinic to community integration, which is a lot of where I spend my boots on the ground, is really taking programs like the Vision Mobile, vision screening out into the community where we know that there is access issues. And so we're beginning to do those kind of reach outs from our clinical teams actually into the community in pediatrics as well. One of the last efforts that we're just beginning to start is to take our pulmonology team and to develop some mass screening asthma activities and partnering in North Omaha with the Empowerment Network as well as with Charles Drew to be able to not only identify those people, but really get them into care and to control their chronic disease. School health and wellness, we're continuing to do focus in that area with education, mostly for and supporting of the school nurses, in especially Omaha Public Schools and West Side Schools. We recognize that they have an administrative task for doing screening, but they also are the biggest triagers of where children spend most of their time in the day. And so we need to be able to help them help their students to have good health so that they can learn and so that their life trajectory can be as full as it can be. Obesity prevention strategies, we lead that along with some others in the community to really focus on health and wellness with programmings like Go Knapsack, which raises the bar for young children in our community in daycares to actually have high standards of physical activity and healthy food and nutrition. We're part of that Step Up to Quality program. We have a component of that is just our daily work. And then working hard to create this data. And that's a hard thing in children. At this point, we still are struggling with looking at the data in our community through a child lens. And yet we're starting to just get a little bit of a focus with some of the electronic health record information through children's that we'd like to be able to partner with others in our community to gather their child health data so that we can get more of a complete picture of what it really looks like in our community, so we address those things that are clear for all. So a lot of time on this slide, but this is kind of the nuts and bolts. I am not, unlike the Methodist program, I am not going to talk about all of our stuff. We have way too many things. I wouldn't do justice to them, but I gave you a handout that you can read about all of our implementation strategic plan that talks about those 4 areas, all the mental health work we're doing, all of that. And it really is truly, and I say this with full confidence, we have really stretched out of our comfort zone, even though we still are in our wheelhouse because that's what we know how to do. But we're out of our comfort zone doing those things that we really are not just the traditional healthcare of the day kind of pattern. So I'm real proud of that. And I wouldn't say that if I really didn't believe it, okay? Okay, so systems is what we're about. We're doing education with telementoring. So we're using telehealth in a way that educates not only primary care providers in our community, but outside of our community, sharing our expertise across a Zoom platform that allows folks to continue their medical education, their nursing education now, and that's through a project called Project Echo. We have, I'm going to flip to this, we are now the recipient of part of the school wellness program, funding from the Nebraska Department of Education, and we are focused on the chronic disease part of this. And so we've been asked to go assist 9 rural districts to help the school nursing team, the provider care team, and the public health all merge together to work to help the children in their communities who have chronic diseases like asthma, diabetes, seizures, to thrive. And so we have a staff member, Kim McClintock, whose job it is to be a school nurse coordinator. Again, early childhood health, we have a pilot now in Lincoln, Nebraska, that says we are bringing a Connecticut Children's Program, national program of Help Me Grow. And it's similar to the Aunt Bertha project that you've heard before, where it really is that identification of resources that are in the community that deal with a wide range of health issues, which is transportation as well as food, housing, as well as health care. And getting that information available and in the hands of the family and the community, as well as the health providers who need it, and then circling back to keep that continuous improvement. We're piloting it in Lincoln and then would like to take it across the state.
Is the name of it bringing
It's
Help Me Grow?
Help.
Bringing Help Me Grow?
It's Help Me Grow.
Help Me Grow.
And it'll be, here, I'll flip to the next thing. So this is the model, Help Me Grow Nebraska. And it has a centralized point of access for all that information, similar to our 211, and yet enriched and a little more vibrant for this specific group of services, which is the early childhood. We have given out grants for childhood obesity. We continue to do that because we recognize that sometimes you need startup money to figure out how to do what you need to do in the community, and these, so we've continued to do that, and we'll continue this in the future. There's the Project Echo, which is that telementoring project. Okay, then I've talked already a little bit about the clinic to community piece. We are continuing to thrive in that way. What else did I want to say here? The target population for the vision piece are the Title I schools in OPS. And so we partner with the health services coordinator at OPS and review the list of schools every year, and then the capacity of the school nurse and the principal, and if they've been seen before by our program, and decide if they're on our screening list. All the children still get screened for those mandatory screenings, but it's just not done by our team across the way. So we're continuing to do that. Just trying to think. And this is our, and I've given you all a little card. This is our webpage, so if you want to see more about our community, the pediatric community health needs assessment, our community benefit report, it's all on this slide, so you go to www.childrens.org, Advocacy, click on the community advocacy, and they're all posted there for everybody to see. Okay. Here is our part of the community benefit discussion. So this is actually the 2017 numbers. Our report is still being printed and finalized for 2018, but it will be done probably in the next 2 weeks. I know some of the numbers, so I can speak to them, but I can't publicize them yet. So our total community benefit was $115 million to the community. And in that picture, we split it, and that's the tricky part with, you can have all the components of the 990 form, the financial form, and you can mush them however you want to describe this. And how we have decided to do that is we have a broader community health part, which includes those things underneath that category: cash, subsidized health care, health professions, education, which is really the major part of that bulk of money. So why it's so high is really that health professions. We educate nearly everybody about children and health in our region. Okay, we have we had about 20. Oh, no, the region, we cross Potawatomi County, a lot of southwest Iowa is us as well, even into some South Dakota, tips of South Dakota, and kind of halfway between Kansas City and Omaha is kind of our boundary for a region.
So you're already, and that's on your children's, in this hospital, you use some boundary, time to last.
Mm-hmm. Yeah.
And you're closest to the hospital, and this is how you got
We're,
the closest to the hospital.
yeah, well,
Closest to
Kansas City, and then, yeah, Des Moines, Iowa City. Mm-hmm. And then Denver on the other side. So uncompensated care, because for the Medicaid expansion, that doesn't directly affect children because they already are part of Medicaid, but the children who age out of Medicaid proper, they would be potentially eligible for that, as well as those families, the parents of the children. And so that's where we're going to see some hopeful increase in utilization by the children, because if the parents have insurance and they're taking care of health, then I am very hopeful that we'll see an increase in upswing of Medicaid recipients for those children who maybe haven't had that opportunity before. That's the only way it's really going to affect our pie at this point. Uncompensated care is there, and that ours is very large, as you can compare here. I have a pie too. So our uncompensated care looks like that. Okay, that's what happens when you have Medicaid as a big payer, is that you get some of that, as well as and then we have a little piece of community programs and services, and that's because these other numbers are so big. Okay, it's a lot of money, but it gets overwhelmed by the different payer mix that we have. Okay, what else to tell you about this? The 2018 numbers, I'm going to go back, maybe, if I can. Let's see. I might have done it. I'll just talk to this. The 2018 numbers, the total community benefit ends up being $318 million. So it's gone up 2.5 times what it was in 2017. So a lot more community benefit that we're seeing, because, and honestly, we haven't changed how we're collecting that information yet. We need to do that. We need to do a better job of documenting what's community benefit. It's exactly the same collection method, so we know that it's really just an increase in that uncompensated care and broader community health piece. The broader community health segment, which includes that subsidized health care, is 3 times greater than it was in 2017. Uncompensated care is 2 times what it was over 2017, and the community programs is just about 40% more. So more in all of those buckets. And so I just wanted to leave you with the last, is that our goal is really to improve the life of every child, and in order to do that, we have to in our community, not just take care of those folks who make it to our door, and to really internalize within our organization the idea of populations and community outside of our doors. And that is just beginning to happen, I feel, as very candidly in our workplace. Open for any questions.